special thanks to our HOD and Professor Dr. Paluk for guiding and mentoring presentation. 25-year-old lady, resident of Mehboob Nagar, Telangana, profession, a right-handed individual.
Your voice is
Voice is
breaking,
not.
Temur.
It is breaking, Temur. Your voice is not clear.
Hello.
Yeah, now we can hear you.
Yes, sir.
No, Temur.
Yes,
Temur,
sir.
voice is breaking. Not at all clear.
I think it's something to Timur,
Shall I
now we are able.
disconnect and reconnect, sir, or is it audible now?
Now you're audible.
Now
Now
it's
you're
audible.
audible. You be like this and speak. Yeah.
Okay, sir.
Yeah.
Came to our OPD with the chief complaints of inability to flex the right index finger 15 days back. Gives the history of injury to right index finger 15 days back while working in the kitchen with a knife. Following this, she was taken to a nearby clinic and she underwent suturing of the wound, and suture removal was done after 10 days. After the wound healed and dressing was removed, she noticed that she is not able to flex the index finger and thus presented to our OPD for further management. There's no significant past history. Treatment history, patient does not give any history of any repair of deeper structures at the time of injury. There's no history of any post-operative splinting or physiotherapy. There's no significant family or personal history. The general physical examination, patient is conscious, cooperative, and coherent to time, place, and person. There's no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. The vitals are stable. On local examination, on inspection, in comparison with the normal left upper limb, with the patient in the sitting posture in broad daylight, with prior consent for examination and hand resting on the table, the attitude of the right upper limb, forearm is in supination and wrist is in a neutral position. There is extension at the PIP and DIP of the index finger. Remaining fingers are in flexion at the MP, PIP, and the DIP joint. The thumb is in mild flexion at the metacarpophalangeal and the interphalangeal joint. A single healed scar of size 1 into 0.5 centimeter distal, 0.5 centimeter distal to the proximal IP joint over the volar aspect of the index finger is present. On palpation, all inspectory findings are confirmed. The range of movements, the MCP joint, active flexion and extension are normal in all fingers. For PIP and DIP joint, the active flexion is not possible in index finger of the right hand, both at PIP and DIP. Passive flexion is normal in index finger. Extension at PIP and DIP are normal for index finger. Other fingers and thumb are normal, normal on passive and active extension. There's no sensory loss distal to the scar. There's a radial and ulnar arteries are palpable. Diagnosis, post-traumatic flexor tendon injury, zone 2 of right index finger involving FDS and FDP tendons of 15 days duration.
Good. No sensory loss. Sensation is normal.
Sensation is normal, sir. There's no sensory loss.
Yeah, good. No? I have a echoing noise. I think somebody else can mute. I think others can mute. I think then it'll be all right. I think some of the. Yeah, now it's fine. I don't know how it's fine. How it got fine now? And now it's excellent. Okay. Are you able to hear me, Taimur?
Yes, sir.
Yeah,
Yes,
right.
sir. Yes,
No?
sir.
So now you got a zone 2 flexor tendon injury. Diagnosis is right. Okay. As I told you, in plastic surgery, In many of the other things, exams you start with the physical findings. Most of the time in plastics, the diagnosis is written on the face. Okay, you do all the work to get the diagnosis, but here the diagnosis is very easy. Okay, so now what will you do, Timur? It's 15 days old. Zone 2 flexor tendon. I completely agree with your diagnosis. Okay, so now what will you do?
I would like to investigate. I'd like to go for an. I would like to get a high resolution ultrasound done.
Yeah.
Yeah, so that
Again,
they
your
can.
voice is breaking.
Voice is breaking,
It's
Hello.
not clear at all.
Hello.
Yeah. Hello is fine, but maybe no. You just speak, Now that we have,
Am I audible? Hello. Hello.
yeah, that's fine. Yeah,
Is it audible, sir?
yeah, audible. Yeah, come along. Maybe now you just speak into the mic or something. Whatever the way same way you did, you
Yes,
speak,
sir.
it'll be fine. Yeah, that'll be fine.
Yes, sir.
Yeah.
So I would like for a high resolution ultrasound of the right and the curtain of the injury side, or whether they have retracted proximally. And
No, again, sorry, Timur, we lose you. We lose
Timur,
your.
are you using
Why?
a headphones or something? Are you using any wired things
no, sir.
for
I'm
speaking?
directly using my laptop and I'm directly speaking on my. I'm
Oh, okay.
using everything is switched off on my screen. I don't know why. I think some connection problems. I'll just rejoin, sir. If I disconnect and rejoin, is that
Yeah, okay, rejoin
hello?
and then, yeah.
Okay, yeah.
So meanwhile, now, if any of the people have got any questions, in this, or we can even talk about this. How
You
is
can
it? How is it, Sandeep? Others, can they talk or the others can't talk? They
you can
only
also
can.
they can also talk.
They
They
can
can
talk.
talk, sir.
Oh,
They
I see.
can
They
talk.
can.
So
They,
They
they
can.
also.
unmute and they can actually speak also.
And make okay. That's right. No.
Yeah.
So if anyone has got any questions, they can. Uh,
Hello.
yeah.
Yeah.
Sorry to keep you waiting, sir. Is
No,
it
no.
audible now, sir? Is it
Yeah.
Yeah.
clear?
Yes.
Yes, Timur.
So these are the investigations I would like to go in this patient.
Mm.
Surgical fitness and anesthesia.
Okay.
Go for the treatment.
Yeah.
My
Okay.
treatment
Tell
plan.
now. Yeah.
Yes, ma'am. First, positive aspect.
No, Timur, we lose you. What we could do is that now that the case is known to everybody,
Yes,
maybe
sir.
maybe Shruti or somebody,
Nishant.
or Nishant,
Nishant, yeah.
yeah, they can tell us to what you do. We'll ask questions and then so that so many people are on the line, so that we'll get to their point. No.
Doctor, other PGs are there, sir. Fast.
Yeah. Any one of them can tell. No, okay, I can ask
Yep.
questions. Get one of them on the line. Okay. Is or the other two speakers, who did before, their voice was good. Shruti or Nishant, they can start also. It's fine. Or
Okay.
any other pages also, if they are on, they can tell. I can ask questions. Now that all of us know, it's the zone 2
Yes.
flexor tendon injury. He's an educated person with mobile nice joints, and it's the injury is at the level of the just at the PAP joint level. No sensory deficit in the other side. There's no other injuries. Now it's a straightforward, no. Okay, what do we do and how do we do? How do we get access? These are the questions, which we forward on, no. Get one volunteer.
Fast. Can you answer?
Yes,
Yeah. Any volunteer? You tell me your name, and then I can catch you, and then I can keep asking.
sir. I'm Dr. Fayaz here, sir.
Yeah, okay, Fayaz.
Second year. Yes, sir.
Very, very good, Fayaz.
Yes, sir. Sir, I think we'll have to explore the wound, sir. So
Mhm.
there is a scar in the index finger
Yeah,
over the
yeah,
volar aspect of the index finger.
It's a question. Sorry, what's your name?
Fayaz, sir.
Fast. Okay, fast. There is a transverse wound, no? The first question
Yes.
is how will you extend this wound?
Uh, we can we can extend the incision on the mid-lateral aspects of the finger.
Yeah, mid-lateral aspect of the finger. So if you put it on the mid-lateral aspect, no, you get only one line, no? Either you have to raise the
On either side, sir.
how do you go to on either side, man?
What are the
What you have to do is that no, there are two lines, no. So why do you say you will extend on mid-lateral line? Now, what is the sanctity about extending on the mid-lateral line?
what?
If yes, why did
To
you
prevent
say?
contractures, sir.
Yeah, why is it not contracting? If yes, why mid-lateral line in incision does not contract, whereas you put it in the middle, it contracts. Is the skin different?
Yes, sir. On the volar aspect, it is the palmar skin is more thick, and on the dorsal aspect, it is more loose,
Okay, but then if you say
more
that
areolar
point,
tissues.
yeah, Piaz, if you say that point, Bruno's incision, where does it go? Does it go in the volar skin or in the dorsal skin? Where does it go? Brunner, have you heard of the Brunner incision?
Yes, sir. Yes, sir.
How does it go? Which skin it goes? It goes on the volar skin.
It's volar on
And
the volar aspect.
then why does that not contract?
Shalina?
Yeah,
Yes.
yeah, it's a very nice question, but actually very difficult to answer this question. So I think for benefit of time, I myself will answer. So
Bruno,
Yes, sir.
yeah,
more like
Shalina, you want to answer, Shalina?
yes, sir, it is more like Z plastic, so it lengthens the scar, so it should not.
No. It does not lengthen. No? Brunner incision does not lengthen the. See, I think that is one of the good principles to learn in plastic surgery. I went a lot of disturbance. Somebody else other than speakers. Can you please unmute? So mute, please. Yeah. So I think one of the principles we have to learn, Shalina, is that whenever any incision crosses a joint, okay, whenever any incision crosses a joint, if the length of the incision does not change in the movement of the joint, then that scar will not contract. Okay, so I'll repeat it again because it's got a lot of meaning. And once you understand this, that means your designing incisions will become easy. Okay, so you find that whenever an incision crosses a joint, okay, and if the length of the incision does not change with the movement of the joint, then that scar will not contract. So now you all of you know flex your finger, and you will find the points with the points mid-lateral line points and you look
Yes.
at that level, and then you straighten it, bend it, the length will be the same. Okay. So similarly, each of the finger has got three segments. The center point of the segment, and if a line passes through that, you bend it, straighten it, that line will be the same. So that's the reason why Brunner incision doesn't contract. Yeah, mid-lateral incision does not contract. So once you understand that, so whenever there is a scar, I think if a flexor tendon injury, incised wound which has healed, what you will do is that you will straight either go back to the mid-lateral line and then go along this side and that side you'll go. So the way to do that is you need to the edges of the scar, you need to open the scar, and then you'll go to the mid-lateral line as early as possible, and then go along with it on one side. You go to the mid-lateral line on the other side, and to raise the flap, you need to like a Brunner incision. You have to go. You need to go. Then you raise the flaps. Okay, understand?
Yes, sir.
Yes.
Yeah, I think once you understand. So similarly, if you want to do an incision across the knee in the popliteal fossa, if you put a straight incision, so when you bend your knee, the incision will be smaller. Whereas now you go up to the popliteal fossa, and then put a transverse incision, and then go to the side, then you will find the incision that is crossing the joint does not change its side. So then again, it will not contract. I think that's the principle no, of making incisions across the joint. So okay. So where will you put the incision more? Whether it will be on the proximal side or distal side. How do you? Is there any way to decide?
More on the proximal side because tendons tend to retract towards the proximal side more.
Now, is there any other way of thinking, Sharina? One of the things you need to think, you need to ask them, how did that injury happen? You have to ask. Okay. So suppose if they say somebody tries to assault, somebody catches the knife, that means it's a flexion injury. Okay, it's the injury in flexion. So then what will happen is the distal cut tendon will almost be very near the DAP joint. So then you will find that means you need to extend the incision more on the distal side. Or suppose if the hand is like this, hand is straight, and then you cut an incision, no? Then what will happen is an extension injury. And then what will happen is you'll have a lot of tendon on the distal side. You must almost have that much tendon on the distal side, and the proximal end will contract more. So in flexion injuries, okay, in flexion by the history you can know. Somebody trying to catch a knife, okay, when it is held flexed, it is injury. In a flexion injury, you need to extension has to be very distal. In extension injury, I think the amount of incision extension will be more proximal. Okay, that's some just these are all thoughts, fine. So now that you have ultrasound, you can, they could tell you that, but then I find that this is much more easy and good than relying on ultrasound. Sometimes that means you are relying on some other person, how good they are. It's very interpreter related. Okay, but then if you have a good ultrasound and a good person seeing it, you can tell us where they are. Okay, it's a very very good instrument. It's an extraordinarily good thing. You can tell what they are. Okay, you open it up and then you find this thing. Will you repair both the tendons or one tendon? Yes, somebody
So
answer.
it is ideal to repair both the FDP and two portions of FDS. But because it's in the zone 2, there may be a possibility of all the three tendons getting uh, stuck in between while the tendon is getting flexed.
Mm-hmm.
Uh, if intraoperatively you find that, then it is better to uh, suture the FDP first.
Mm-hmm.
Give importance to FDP more
Mm-hmm.
than FDS.
See, what is the advantage of repairing both, Faisal?
Uh, uh,
Okay,
you'll have better.
see, for example, now one guy has repaired both, and only FDP has been repaired in the one person. Of course, they'll be able to range of movement will be full. And somebody asked, what's the advantage that this guy has later on? What's the advantage he might have?
Grip strength will be better, sir.
Yeah, it's correct. No? Actually, FDS has got a better grip strength. FDS is for power, and range of movement of FDP is excursion length. Excursion length of FDP is more. Okay, so if you FDS is a very powerful muscle, so you do have good powerful this thing that you have. That's one. And secondly, some of these people, if you don't repair FDS, if you very hyperextensile joints, they may develop a mild swanneking. They may develop. Okay,
Yes.
because FDS is not there, they might have a small
Span.
that again can they develop. That's the one. And if you repair a good FDS, and I always found if the FDS is repaired well, the range of movement of the FDP is easier to achieve because what happens is that gives a good platform. No? That's a smooth muscle, smooth, isn't it?
Yes.
Yes.
Yes, sir.
So the FDP can glide very well in that. That's one. And some people say because the winkle also goes through that, and it undisturbed vincula is we get. But then if it is there for 15 days and all that is like that, okay. So then what would happen is it doesn't really much matter. No. So these are the additions you'll have. Okay.
Yes, sir.
Okay,
Yes, sir.
right, good. No, okay, good. So repairing one tendon and both tendons is fine, right? So and
Yes,
then
sir.
then how will you repair? No, how will you repair the tendon? What is the choose your technique you'll use to repair?
We'll use a modified Kessler technique, sir. Either we use a proline 30 for that, and followed by an epitendinous suture using a proline.
You use the word modified Kessler. No, what is the modification? What is the original Kessler then? So is there a unmodified Kessler and a modified Kessler?
Original
The
Kessler
knot lies outside
not.
between the two repair sites, and in
Yeah,
modified Tesla, the knot lies inside the repair
yeah, yeah. That's
site.
right. So I think we got a very young participant also there in the class. Somebody learning plastic
Yes, sir.
surgery.
Yes, sir. Right from the childhood, they are learning
Yeah,
plastic surgery.
I think very young, but I think you need to photograph that child, So that is that the first time I attended the class, I attended SRS class when I was a toddler. Okay, right, no. So I think that's the correct answer, no. So the knots are outside, the knots are inside. Okay. So yeah, why do you use the epitendinous suture, Faisal? What is the reason for using epitendinous sutures? Or what is the function of those sutures,
Sir, it will make the repair more flush, sir, and it will kind of bury the previous core sutures.
Core suture anyway. No, you're not not okay. It makes the range down, but then initially it was thought so. I think when we were all students, that's the only function that was taught, and later on, I think a lot of disturbance, Sandeep.
Uh, yes, yes. Yeah, now I think it stops. Somebody's mic was on.
Yeah, I think humble request.
Yeah,
I think
yeah,
those of you who are not speaking, can
answering.
you all
Yeah.
unmute? No. Okay, if you unmute, it'll be nice, because there's a lot of
Noise. Yes.
echoing and all there, and also speech. So
Shravan and
initially, sorry.
no, no, Shravan, in case somebody switches on the one, if they are not speaking, please switch it off. La?
Yes, sir. Yes, sir. I'll do that.
Yeah, thanks, thanks. So,
Yeah, yeah,
please carry on, sir.
yeah. So initially, it was thought, that epidemic switches are only for making it tidy. But then you find, about they add up 1/3 of strength to that. You add 1/3 of the strength. You will be adding it to that. So that's again is a very important thing. No longer they are considered as things which are ready. Okay, so that's very important. Okay, so have you heard of So have you heard of 4-strand switches, 2-strand switches?
Yes,
Yeah.
we suture it for the ones the two strands are between more
Again,
Kessler, and it will become a four-strand suture.
yeah. If you
So
put
we can do the number of strands, but the point is it will increase the strength of our repair, but then it will make it more bulky, and it will prevent some gliding between the pulleys in the fibroosseous canal.
No, your first point is right. Your first point is right, stating that if you use increasing the number of sutures, increases the strength of this repair. Okay, that is correct. But the other point is not right. You say that it will make it more bulky. No, that is not right. Okay, if you do it properly, it does not increase the bulk. So you need to do a Kessler. The point is why it needs bulk is the technique. So the right technique is when you take in a bite in the Kessler suture, your needle passes through the open end, right? The bare tendon it takes. But then it must come about 1.2 centimeters, 1 centimeter at least, it must come away from the cut end. The commonest problem why all the problems happen in the flexor tendon repair is it comes to too close. Okay, you just take wherever the needle goes. You have to be very patient. Your point of entry must be in the middle of this thing. If you take anterior and posterior, it must be evenly placed in the middle, and then you have to slowly, nicely you have to go wade through it, and then get into the. You must get in 1.2 centimeters away. You must get, and then you do that. And afterwards, you put another suture which comes about a point 0.8 centimeters or 0.9 centimeters away, 3 millimeters from there. So then you put in sutures, then it won't, you won't have a problem. If you put it about 5 millimeters, 5 millimeters, both tendons you put like that, then you get into a big bunch you get. Okay, that's the reason you get a bunch. What's the advantage of doing this? Okay, you get more strength. Even with two strands itself, you get more strength. Then why are people advocating four strands? Any idea, any advantage of the 4 strands?
We can
The
only
advantage of
active
increasing the
mobilization
strands
can
is
come
that
at.
if you're planning for an aggressive physiotherapy
Yes.
regimen, directly we start if you're planning to start active mobilization, then
Yeah.
it will be more beneficial to keep a 4 strand or a 6 strand.
Yeah, yeah, that's right. No, so that's the right answer. No, yeah, 4 strand suture. If you do it, it will increase the strength of the repair, and you will be able to start active. There are a lot of various protocols, physiotherapy protocols, and if you want to use right away active motion protocols, some of the protocols are active motion protocols straight from the day 2, okay, immediately after surgery. For them, if you want to do that, that means you need to have 4 strands. Okay, so I think that's the reason you need to do that. So usually when you do a repair, the strength of the repair is the strength of the suture. Immediately after the repair, what is the strength of the repair? The strength of the suture. Yeah, yeah. Repair, is a little weak. It's very weak at one week of from the time of repair. You will find that they almost go down by 1/3. They go down. Okay, the strength, strength to break up is almost 1/3 low about 1 week later. So at that time, what would happen is, if you want to really, gentle movement is 500 grams means, if you want to make a small grip and it's 2,500 grams, it will come. So then if you use only a 2 strand, at that time, this will not hold. Then what will happen is, it will gape. Okay, that's the reason why you are using a 4 strand suture. But then if you are going to use a 2 strand suture, that means, you must not go for a early active motion protocols. You must not go. Okay, you must use the different type of protocol. You have to use the suture. Okay, right? Okay. So you have done a repair. Okay, it has healed well. Okay. Now let's talk about a little bit about 8 o'clock. No? So we'll talk about a little bit about therapy. No. So who can tell me after the zone 2 repair? No. Faisal, you're there?
Yes, sir. Yes, sir. I'm here,
Yeah,
sir.
yeah. Yeah, you tell me the therapy that you will make. You have to tell me exactly nicely. You have to tell me. Okay.
Yes, sir.
Yeah, tell me,
Uh,
please.
so we followed Duran protocol, sir,
Very good.
of early passive mobilization.
Mhm.
So within 48 hours of repair, we advise passive uh, flexion and extension uh, uh, of the MCP, PIP, and the DIP joints, sir.
So how can you do passive extension? I mean, that means you will be stretching
With,
this thing, no?
within sir within the constraint of the slab, sir.
Yeah, what
So
you have to do, main thing what you have to do, even that, you must do a passive flexion of the fingers, and then you must ask them to do active extension. But when you say passive extension, many time it might be misconstrued. You might do a lot. So you allow them to actively extend, but then most important is that you must passively flex. Okay, that's
yes,
what you must do. No, so you start off with that, then. Why you are allowing active extension, man? No problem. Why will it not cause damage? You tell me why. What is the principle behind that? So even in Kleiner protocol, no? Yeah, your passively is flexed. Okay, passively is flexed, but then active, they ask you to actively extend, no?
yes,
Why
sir.
do you think when they actively extend, they will not have a rupture? Why is it not? Why do people say, not to worry?
The tendon is not under tension, sir. By I mean the repaired tendon will not be under tension by
During
extending that.
extension? Yeah,
Yes,
that's
sir.
I think what's the principle behind, no? You know, actually, it's because of the principle of reciprocal innervation, no? See, for example, when you flex, okay, when you flex
Yes.
in the mind and the body, no, what happens is, if you want to flex your finger, automatically the extensors have to relax.
Okay.
Okay, if you have no, automatically the fingers, the extensor have to relax.
Yes,
So
sir.
only you'll find no. So suppose you find elbow flexion, no, 5-6 will be the innervating this thing. Okay, C
Yes, sir.
5-6. The opposite will be 7-8. It will be okay. So you will find a different dermatome, the different nerve roots will be the main innervating muscles of this. If this is 5, 6
Yes.
elbow flexion means 7, 8 will be the main things to do. So you
Yes.
can't flex your finger if the extensors are also not acting at the same time. So
Yes.
automatically a signal comes in to say the extensors to relax. I think so credit to the client, this whole thing, tendon evolution comes up because the understanding of some basic science hitting, okay. So I think
Yes, sir.
it is this thought, so which really made the whole flexor tendon things to do. Because they found because you suture it, and then if you pull it, then they thought, oh my God, it's hitting. So passively, if
Yes.
you pull it, then it's bad. If you passively pull it, the power that is exerted is the power you have. If you come after lunch or breakfast, you can pull it too much. Okay, so that's right. But then if you are actively asking him to extend, then it's very unlikely to cause any damage to the suture line because the flexors are not acting at that time.
Yes, sir.
Okay, the flexors because due to the principle of reciprocal innervation. Okay,
Yes, sir. Yes,
so
sir.
that's the reason. No, so
Yes,
you
sir.
ask you passively you will flex, and
Yes, sir.
then you will actively extend. Then what? How do you
Sir, I would
progress? No?
also like to add a point, sir, that we first put a slab, sir,
Mm,
in flexion of the wrist at 30-degree flexion, MCP
yes,
at 60 to 70-degree flexion, and IP joints in extension, sir. So this
correct,
is for
correct.
the first 4 weeks. Followed by in the next 4 weeks, I would like to I will tell the patient to, I mean, we'll change the slab first and slightly reduce the flexion of the wrist.
Mm-hmm,
We'll reduce it from 30 degrees to 15 degrees.
mm-hmm.
And then again, we'll ask him to passively flex the fingers. And also, uh, uh, while he passively flexes it, he has to press and hold that finger.
Yeah. See, same thing. I think what you have told is if I want to, there are a lot of listeners. I'll tell exactly how you should do, how you should tell. So your plaster is right. Okay. But
Yes.
only one more thing now you need to see is that now you must put this plaster when the forearm is in supination. Okay, repeat it again. This is one
Forearm.
single, it's one single mistake that's done many times. Yeah, all of you think, if the forearm has been supination. I always tell when you have to flex it and repair, the palm has to face the face. If you keep like that, you'll remember. I think every time you put, you remember me. Okay, yeah, palm has to face the face. Suppose if you put it in pronation, okay, sometimes you do a tendon repair and then you see, okay, some fellow will be holding, okay, like this, oh, it stands nicely. You put like this. Then if you put it in pronation, then they come up, they'll be looking like this, as if, trying to bless you, okay? So the hand will be like this, so this is no good. You can't do physiotherapy for a flexor tendon repair if the plaster has been put in. After that, plaster is like this, then you can't turn back. So at the end of surgery, the degree what you told is correct. Wrist at 30, that 70, all are correct. And then you have to also say in your mind you have to think that the forearm will be in supination. Okay, that is
Sure, sir.
then only you can do that. Okay,
Sure,
what
sir.
we do is inside the plaster for the first 2 weeks. What we do is we just flex the IP joints, and then you can passively extend. So at 2 weeks, what we do is that so we passively flex the IP joints, and at the 2 weeks we ask him to just hold there. So we are not asking him to bend it. We are only asking them to hold.
Yes.
Okay, that's the at 2 weeks will happen.
Yes.
So the next at 4 weeks, what will happen? Another 3 weeks or 4 weeks, depending upon how well they go. Then what you do is, you passively you ask them to gently actively flex, not flex fully. You just ask them to flex as much as they can flex, and then you continue the passive.
Yes,
Okay,
sir.
that's the next one you'll do. The last one, what you'll do is, you get a passive, active flexion and hold. Okay, and then meanwhile, same time, you're also, slowly as it goes, passively extension. We should keep
Yes, sir.
giving. Okay, so when you are doing this, which patient, you'll feel, what is the complication of therapy?
Tendon rupture, sir.
Yeah, tendon. How do you know that it is ruptured? How do you diagnose rupture?
Sir,
How do you know the tendon is ruptured?
there'll be an extended attitude of that injured finger, that ruptured finger, sir.
Yeah.
That
Uh,
cascade.
The most important, the patient will tell the patient 100% of the times the rupture is diagnosed by the patient. The fellow now who is the hand will be, finger will be in a position, he'll have a hole, and then he says, Sir Panita, I was continuously keep doing this, suddenly I had a foot and then finished. And then after that, I'm not able to move. 100%. There is no rupture without this patient telling this sequence. He was doing this exercise or something, suddenly I found there was a snap, and after that, I'm not able to move the finger. That means
yes,
that thing will be there, okay?
yes, sir.
So that's called a rupture is the number one complication. What's the number two complication? What is it?
Uh,
Now, what's the number two complication? Number two, easy man, easy to tell. No, what's the? I'm not. It's not. I'm not telling anything. I'm not asking anything big. Okay. Not anything big. What is one is rupture is the problem. Then what is the other next complication? Addition formations.
yes, sir.
Yeah, I think it is very simple. If somebody asks you what are the tendon complications of tendon repair, you have to
Yes,
say
sir.
first is you must actually first you must say wound healing problems.
Yes, sir.
Okay, that's what I would expect to ask. First is wound healing, and it's a disaster. If you do a tendon repair and then if the wound breaks down, that's a disaster. Exposing the tendon is gone. Okay, first is wound healing problem, and the second is rupture. Third is addition formation. So is there any way you can find these people have got more tendency to rupture? Okay, well, the answer is if you find when you are doing physiotherapy, suppose you see them at the third week, second week of physiotherapy, third week of physiotherapy, if the physiotherapist tells you, and your patient also tells, say he's doing very well. Okay, yeah, if a fellow says he's doing very well, that means that guy can rupture. Okay,
Yes,
yeah,
yes.
the reason being that means for him the whole
Over enthusiastic.
no, not over enthusiastic. It has also got a, biomechanical problem. So if any guy who is doing very nicely, that means they don't have any additions. That means total healing that is taking place in that guy is the intrinsic healing. So all tendons heal both intrinsic and extrinsic, right?
Extrinsic. Yes, sir.
So the additions are extrinsic healing. Additions are the
Extrinsic.
effort or part of the extrinsic healing is the additions
Yes,
formation.
yes,
Correct.
sir. Yes,
Okay.
sir.
And if the additions are too much, then you get stiffness. But then the whole of the therapy idea is that we have to allow them to form these additions. But then we are controlling the additions. And that means we allow them to form a flimsy additions. Okay, so that they also as because we're continuously moving, as it is healing, the additions are flimsy. They are not rigid, solid additions. They don't form. Okay, so a guy who is moving very nicely, that means it's possible that whole of his strength of repair is only intrinsic in the intrinsic healing. Okay, so that type of people, sometimes they may go for repair. Okay, those guys may go for rupture. So when I find something say very nice, I said be careful. Okay, so you must not rupture. Okay, you must do exactly what is told, nothing more and nothing less. Okay, that's the thing is. So other thing is what is called as a gap formation, but it is a one which you cannot see clinically. Yeah, sometimes the more additions form. Sometimes the repair is not good. What would happen is, they will just leave a little way and find if the tendons must heal with tendons. If the tendon is not healing with tendon, if a small gap comes, more than 3 millimeters of gap at the repair site, that means the results will be bad. So
Yes,
that's
sir.
the reason, your tendon repair, the quality of tendon repair must be good because if it gaps, the gap is filled up by fibrous tissue. Okay, the gap is filled by fibrous tissue, so the strength of the repair will be less. So that again, that again, can go for rupture. Okay, so these are the points, fine. Okay. So somebody has gone. Okay, are you able to hear me? Somebody said audio, some noise I heard.
Yes, sir. We are able to hear you, sir.
Yeah, we are able to hear you.
Yes,
No?
sir. Now
Okay.
yes, sir, we are able to hear you, sir.
Yeah, you're able to hear you. No? So
Yeah.
now it's all clear. Okay. So I think that's the way now you'll do a. Just any questions that you have. So so I need to leave by 8:15. Okay.
Yes, sir.
So
Just one question is there in the chat box,
please.
sir.
Yeah.
Yeah, sir, that Dr. Srinivasu has asked one. Can
Yeah.
you repeat once again the mobilization principles with duration?
Yeah, correct. No. So
Yeah.
normally, most of us do a durance repair. Okay, and, normally most of us do the durance method of as what Faisal told me. That's fine. That works on a really well. So you must do a plaster. I think you must put in when you do a plaster, you must put a 6 inches plaster. Okay, not a 4 inches plaster. Okay, and because it must cover the sides, and it must come like this, and your plaster must go about a centimeter beyond the fingertip. Okay, that's true. It must go beyond a centimeter beyond the fingertip. Okay, that it has to go like that. That's very important. And then after that, we keep them elevated, and then we start physiotherapy at 40 days. Suppose if I do it on Monday, Wednesday morning we'll start the physiotherapy. Okay, the physiotherapy that is started is gently inside the plaster. So you take off all the gauze pieces over here. So inside the plaster, you will flex the finger. Okay, you will do it, 20 times, 3 times a day. Okay, you will do it. Flex the finger 20 times, and then gently, ask them to extend. Okay, that's it. No? So gently ask them to extend. So like this, it's done. For the first 2 weeks, it's done like this. Okay. At the end of 2 weeks, what we do is you just flex the finger and then tell him when you're at almost at the very end, you tell them, okay, just hold. Okay, you're not asking him to bend the finger. So you flex the already you have flexed the finger almost to the very end, and then you tell them just hold. Okay, like that he will hold. That like that same repeatedly 20 times, 20, 4 times a day you repeat, and sometimes the people repeat alternate hours or so the waking time. So once you do that, then what you do after 4 weeks, you just ask them to initiate the flexion. Okay, they'll just do a little bit. Then don't ask them to struggle. No, they'll initiate the flexion, and then that's called active flexion, passive assist. You passively assist it down and bring it down there and hold. Okay, that you'll do for 2 more weeks, and then afterwards, what will happen? Be more active. Throughout the same period from 4 weeks, you will also know when after they extend, you also passively extend a little bit. Okay, so that's so in the essence, you get both flexion also you are improving, and the extension also you are improving without stressing the repair. Okay, that's the idea. Okay, so you need to also understand that the strength of the repair is the worst at around 1 week of time. Okay, a lot of people think, okay, I repaired it today instead of doing it on second day, I'll do it on the seventh day, eighth day, and like that. But in fact, you should remember that the strength of the repair is the weakest at that time because lot of, some sort of chemical at the site of repair, they also know some additions. All these things are lysing, so the tissue is not very good. So it's better to do it early. And there's also a matter of principle throughout the body. They have found the strength of the repair increases when it is stressed. Okay, I think that's the point. No? So it was initially found out in bone. You will find a
No.
lot of times, they'll put external fixator when the callus is seen and all that is there. No sort of thing is there. What they will do, if an orthopedic surgeon, when you're done a flap, they'll remove the fixator. They'll put a cast and said walk. Okay, why are they walking that? No, because they are making the stress. They find that amount of stress that you give, it allows you to, it increases the strength of the repair. Same thing is followed in the tendon also. So you're giving it controlled stress you are giving. So when you give a controlled stress, it increases the strength of the repair. Okay. So I think that's the philosophy in this. After 4 weeks, what you do, you can replace the plaster with a thermoplastic detachable splint so that they clean it and then they start doing. At 8 weeks, you start asking them to do gentle exercise, the activities of daily living, gentle handling of things. I think by 12 weeks, they must have a good range of movement. They must have. I think that's what we would aim at after doing a flexor tendon repair. Okay.